Hello, everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today's topic is championing health workers' well-being and mental health. And over the next 45 minutes, we will discuss how organizations can address the pressing issue of health workers' well-being and mental health. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. Let's just take a moment to go over your experience today as an attendee. If you're joining us on Zoom, you will see a dark menu bar at either the bottom or the top of your window. There you can access a selection of resources related to this webinar, including today's slides. There is also a link to stepsforward.org where you can find all of our past toolkits, podcasts, and webinars. If you don't see those options, select the three-dot more button to access the resources and Q&A. If you're joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom, access the resources, and ask questions for our speakers to answer. After our webinar concludes today, you will be able to claim 0.75 continuing medical education credit hours. You can follow the link in the resources tab to the AMA Ed Hub and claim the credit there. We will remind you of all this at the end, but for now I'd like to go over today's learning objectives. We have 3 for you today. By the end of this, you'll be able to explain the critical need for systemic action to address mental health stigma and barriers to help seeking among healthcare workers, including the impact of credentialing and licensing processes. You'll also be able to discuss successful strategies and policy changes, including language reform and credentialing and licensure that health systems, hospitals, and advocacy groups have implemented to support workforce well-being. And finally, you'll be able to utilize available tools and resources to drive further change, champion safe help seeking, and contribute to a culture of mental health support, regardless of one's role in the healthcare system. And the people who will be guiding you through that today will be Corey Feist, the CEO of the Dr. Lorna Breen Heroes Foundation, Daniel Blaney-Koen, our senior attorney at the Advocacy Resource Center here at the AMA, and finally, our moderator, who I will pass it over to, Dr. Heather Farley, the Vice President of Professional Satisfaction here at the AMA. Dr. Farley, the floor is yours.
All right. Thank you, Alec, and welcome, everyone. For those of you who are joining us live, happy St. Patrick's Day, and I appreciate that. I don't know if you can see it, but Corey's sporting a little bit of green for today. There you go. And I will say this is my first St. Patrick's Day in Chicago, and the river is indeed green. So I hope you all are celebrating in your own way. In our time together today, we are certainly going to be talking about a serious topic. But if you know our 2 speakers here, Corey and Daniel, I think we're also going to have a lively conversation and some fun. So welcome, and I will also level set a little bit about that our conversation is not another webinar on raising awareness of the issue of burnout. I think most of us who are on this call are very well aware of that. This webinar and this conversation is about action. It's about system level transformation and the moral imperative that we have to make help seeking safe for every healthcare worker in this country. I know this issue is personal for many of us. Indeed, it is very personal to me. I remember, I'm going to date myself here, but 20 years ago as an intern, I remember being warned by my fellow residents that if I had ever seen a therapist or been diagnosed with depression, that I should lie on my credentialing and licensing applications. Otherwise, I'd be in for a world of hurt. And that really stuck with me. And fast forward 20 years later, as I'm most recently the chief well-being officer of 2 different health systems, and those issues are still there. And I had multiple physicians, nurses, other professionals who either delayed seeking care, didn't seek care at all, went out of state to seek care or self-pay because of the stigma surrounding help seeking. And it's really, in my mind, unconscionable that those things are still happening. And these barriers are real. And today we're going to dive into how far we've come around these issues, because we have made really substantive progress, and there are things to celebrate and give us hope. And we'll also take a really realistic good look at the work that is still ahead of us to make it safe for their healthcare workforce to seek support when they need it. So without further ado, let's hop right in. And I'm going to turn my first question to Corey. And along those lines, Corey, you and your family have turned a personal tragedy into a national movement. Can you briefly share a little bit about the origin story of the Lorna Breen Foundation for those who might not be familiar, and how it evolved into the All In Coalition?
Sure. Thanks so much for having me today and inviting Daniel to join us as well. He has been an incredible partner in all of this work, as with all of the AMA. Alec, if you go to the next slide, so this is Dr. Lorna Breen, the namesake of the Dr. Lorna Breen Heroes Foundation, a 49-year-old thriving emergency medicine leader and physician who was really struck down in her prime at the peak of the pandemic in New York City in April of 2020. Lorna had a very, very brief mental health episode after returning to the workplace too soon, following a very being very sick with COVID-19. And Lorna's deep desire to take care of others before self got her into a position of being so depleted that she needed to be removed physically from New York City and brought to Virginia, where our family is, for her first ever mental health treatment. At the time, I was the CEO of the University of Virginia Physicians Group. That's the medical group that employs all the clinicians at the University of Virginia Health System. And I had been an attorney for the organization. And so when Lorna started to share her concerns with me and her little sister, my wife, Jennifer, also an attorney, that she might have repercussions to her professional license, her hospital credentials at New York Presbyterian for getting mental health treatment, I was dumbfounded. And I was actually, I was in disbelief that in 2020, that could be a thing, kind of as you were just saying, Heather. And after Lorna took her life, we heard from thousands and thousands of families and friends of health workers, parents of medical students and others who said, I am concerned about the safety and well-being of my physician or nurse friend because they can't take care of themselves in a time of need. And so based on that feedback, we created the Lorna Breen Foundation, whose focus is to support the mental health and well-being of all health workers, envisioning a world where seeking mental health treatment is viewed as a sign of strength. And we've really been dedicated to addressing both operational practices and the processes that drive health worker burnout, as well as changing how the industry supports the mental health of our workforce. And we don't just do this in the name of Lorna, though. If you go to the next slide, Alec, we have heard now from hundreds of families of health workers who have taken their lives, and whether it is Matt Gall in the top left corner, or Scott Jolly holding the partial skeleton, or Lisa from Boston, or Mo from Idaho, or most recently Tristan Smith from Ohio. This nurse who just was so passionate about taking care of workers and felt like just when they were about to get the love and respect as workers that they deserved, they got a pizza party in Penn's for the healthcare heroes. These folks and their stories all have the same thread, which was that in a time of need, they put their patients and their profession above self because of the fact that they felt like getting mental health treatment would be that scarlet letter that would ruin their career. And so we continue this work in earnest. And most recently, if we go to the next slide, we along with the AMA, we surveyed health workers about what their concerns were. Alec, if you go to the next slide for me, loud and clear, it came back to us from nurses, nurse practitioners, physicians, and physicians' assistants that the top barrier by far is the external stigma in the form of state licensure, malpractice insurance, and hospital credentialing, requiring answers to invasive questions regarding the mental health diagnosis or treatment, even for usually simple and very preventable mental health conditions, such as anxiety or depression, or I should say preventable, prevalent was the right way to say that. But so that is the chorus that we have heard over and over again. And I think that our partnership, the work that we've done, developing the All-In National Coalition, which is accelerating these solutions with 35 organizations, including the AMA and the Lorna Breen Foundation, it's been remarkable to see this progress, and we have a long way to go, but the wind is at our backs. And with the partnership at the AMA, we've been very effective at knocking down these practical barriers to accessing mental health care.
Thanks, Corey. Thanks for sharing your story, your family's story. I know that you're often asked to do that, and it is not easy every time that you share that, but it is such a powerful story. So let's kind of get them a little bit more granular and dig into those licensing and credentialing language that you spoke about, and start with the basics. Can you give us an example of some of the harmful language versus the supportive and best practice language that you've seen in these applications, and maybe why changing that is so important?
Sure. I think it's important to understand that these questions in and of themselves were of an age where there was a real thought that that mental health was related in some way to moral fitness, to practice. And so to that end, the questions themselves ask inappropriate for inappropriate information, but they're often cohorted next to questions about convictions for felonies, convictions for pedophilia, reinforcing to the applicant that this is the same thing. These are moral fitness questions. So I wanted to just kind of anchor that answer with the lens that of another day that just hasn't worked its way out of this process, and they linger. And so often what we see, and Daniel has some more slides on this, but questions about anything in the past. Have you ever been treated for a mental health condition? Have you ever gone to therapy? Questions like that are inappropriate according to the Americans with Disabilities Act, where the focus should be on current impairment rather than prior diagnosis or treatment. They also continue to reinforce this stigma that getting help is not an appropriate thing for a health worker, and it couldn't be further from the truth. I find it incredibly ironic, frankly, that physicians are prescribing treatment for mental health conditions that they themselves cannot take them without fear of losing your job. And so those are the questions. They often find themselves in the form of, are you fit to practice? Did you have a past diagnosis? Have you gone to a professional health program? Have you ever used an illegal substance? And then the last one, which we find is usually not a direct question, but more of an indirect question on this, is explain any and all gaps in your practice, between gaps in your resume and your practice. And those can be kind of a backdoor way of saying, were you being treated for any mental health conditions? And again, that's not appropriate, and it reinforces this barrier as well as the stigma.
It's a really helpful overview. And in addition, that sort of backdoor question is a sneaky one. You mentioned that Daniel has some examples of specific language. I think we've got a couple of slides on there. If I can turn it over to Daniel and ask him to walk us through those specific examples, that'd be great.
Yeah, thanks, Heather. Let's go to the next slide. And when we're talking about these, I also want to, Corey highlighted, the need for that seeking mental health care is a sign of strength, and the AMA agrees unequivocally with that. It's also a sign of institutional strength that institutions make it possible and support their health workers from seeking care. And the questions that I'm going to go into, the language that I'm going to go into, highlight that. And that's another premise that we start with. Institutions that support their workers getting care for mental health conditions or conditions related to substance use are safer than organizations that put up barriers. So when we talk about consistency and not consistency, the consistency is with national best practices. It's being consistent with AMA policy. It's being consistent with recommendations from the Federation of State Medical Boards, from the Federation of State Physician Health Programs, from the American Dental Association, from numerous pharmacy organizations, with the American Hospital Association, the National Association of Medical Staff Services. And I mentioned some of those because I know that the people on the call today are familiar with those organizations. So this is not just the AMA. This is not just our close partner at the Dr. Lorna Breen Heroes Foundation. This is a broad coalition of state-based, national-based organizations representing physicians, pharmacists, dentists, nurses, and a wide range of other care providers. One of the things about the momentum of this movement, of this policy movement, is that more and more people agree once they start to dig in a little bit. So let's dig in. So you can see the not consistent. You'll see common themes here, and that when the not consistent, have you ever during the last X number of years, and then hone in on that word that could impair your ability to practice safely. Now, Corey and I are lawyers, so we've never treated anybody. Our family gets nervous when we take out Band-Aids. But one of the signs of chronic disease or any chronic illness is the possibility, and this is what the physicians have told us, the possibility that there might be a recurrence of symptoms in the future. And it could be of a physical condition, a neurologic condition. It could be a behavioral condition, a psychological condition. The very nature of chronic disease means something could happen in the future. Our focus is on, is there a current impairment? Physicians and other healthcare professionals want to be safe. So that's why the consistent question is, are you currently suffering from any condition, and so on and so forth. The same thing with that second option. And this is a peer reference question. So we also want our peers to confide in each other. Dr. Farley mentioned, that if she was counseled, if you ever need to get counseling for anything, it's going to hurt your career. Is that someone you would feel safe with going to, with confiding in something, saying, hey, there's some things going on at work that I really need to talk to somebody about. Can I confide in you? We want to encourage those conversations. A question like this means that peer would have to disclose that, well, they confided in me that, well, I guess it could affect their ability to practice medicine if they were really upset. I don't know, but it could. And so that's why we offer the consistent question that the National Association of Medical Staff Services also recommends. Let's go to the next slide. We'll make all these slides available to everybody so you can have this. This is also, as later we get on, there are a number of resources. The Breen Foundation has a phenomenal guide that lays all this out more. Here's the not consistent question. Have you ever used illegal drugs, including non-prescribed prescription medication? We don't ever want people to use, substances non-medically, but it has happened in the past. This is what we like to talk about as the "please don't hire me" question. Even the consistent question is, are you currently engaged in the illegal use of drugs? And then there's a definition there that is supported by NCQA and URAC, and that's really important because I know a lot of people, probably most of the people on this call, they know. I love calls where I can use the alphabet soup like NCQA and URAC. And people on the call, everyone's nodding. Yep, we know who they are. So this is your call. We are your people. This is what NCQA supports. And we verified this. You can trust this. Next slide. And again, these are just another couple of examples about wanting to remove the questions that people have told us cause fear. Fear from seeking care. And it's not just that they've told us. This is the research that's been done by the Physicians Foundation. It's the research that's been done by the Federation of State Medical Boards, by Medscape, by the Heart of Safety Coalition, that is repeated over and over that the fear of disclosure of care when there is no impairment means that people don't get care. So we want to remove this barrier, this literally language barrier, moving from could, has been, in the past, to focusing on whether there is a current impairment, because that's the balance. We recognize that organizations and systems need to know if there is a current impairment. Organizations and systems want to provide support. and that's fantastic. But that support has to be balanced by removing the fear of disclosure of past care.
Thanks, Daniel. This is just really helpful to see the granularity of how these questions are still snuck in there, and what's a better way of asking about current impairment that has some parity between physical impairment and mental health. So I really appreciate you walking us through that. And I also really appreciate the partnership that the AMA and the Lorna Breen Foundation and All In Coalition have had over the last few years. We've been, really strong collaborators, and I think that partnership has unlocked progress and momentum that probably neither one of our organizations could have done alone. And one of the examples of how we've partnered is in our Joy in Medicine recognition program as well. So, we know here at the AMA that this is such a foundational issue for the mental health and well-being of our healthcare workforce. And that's one of the reasons that we've included it within the support domain of our Joy in Medicine health system recognition program. So any health system that is hoping to be recognized must demonstrate that they have removed these invasive questions and stigmatizing language from their credentialing applications, or if they have not yet, that they have submitted an application plan delineating how they will get there. And this is a kind of shot across the bow for future years, that we are intending to tighten this up a little bit, so that we are looking for actual proof that these questions have been removed in the future. And I think that'll be an added momentum and motivation for systems to do this essential work. And so I'll ask both of you, we've now been at this work trying to change these questions for a few years, and we have in fact made substantive progress. And I hear that we've recently hit a milestone. Can you share that milestone with the audience?
I'll start that, because I love to share good news. What's been absolutely remarkable about this change initiative is the pace. This has been so fast when you think about where we began this work. So what you're sharing with folks, by the way, is a map that resides on the Dr. Lorna Breen Heroes Foundation website, drlornabreen.org. We now have over 3 million health workers in the United States working under a licensing board or in a healthcare delivery system where they will not be asked these questions about their prior mental health. And we know that because of the rigor that we've taken through creating a recognition program and a validation tool to make sure that all of those technical language pieces that Daniel just walked through have been shored up, and we validate it. So this map shows that almost 2,000 hospitals in the United States, freestanding emergency departments, freestanding surgery centers, as well as almost 1,000 urgent care centers, have now removed mental health questions. On this map, when you go to the Lorna Breen Foundation website, we've tried to make this the source of truth so that workers can check and see if their organization has been recognized by our Champions Challenge badge, the same badge that you saw at the top of the hour that when Heather began her remarks. That Champions Challenge badge you can find by clicking on any of the bright blue states and seeing a whole list in your state of the organizations who we've recognized. There are only a handful of light colored states, which are states where we have not recognized a single institution. But it is really amazing progress, such that, of the 3 million health workers that are benefiting from this badge, almost 500,000 of them are at the credentialing level. In addition to that, there are medical staff groups, there are health plans, there are professional liability insurers, there are locum tenens firms, which in some credential 115,000 health workers who've also been recognized by this badge. And then if you'll go to the next slide for me, Alec, you'll see the licensing map. Before I start that, I neglected to say something, which is that when we began this work about 3.5 years ago, that prior map was completely blank. There was not a recognized hospital or health system. So our baseline on this was 0. In contrast, because of the good work that the Federation of State Medical Boards, together with the Federation of State Physician Health Programs, had led, in 2018, the Federation of State Medical Boards had unanimously approved the language that Daniel had shared with you just a few minutes ago to remove these questions at the licensing level. And when we became formally involved in this, between 17 to 19 organization or licensing boards would have been depicted on this map in dark purple. In just a few years, now we are at 43 medical licensing boards, and that number is growing, friends, such that now over 1 million physicians in the United States don't have to worry about these questions. Now, I will say you may be sitting there doing math saying Feist said 3 million, and I've just added these last two slides together. The difference comes in nursing licensing, dental licensing, pharmacy licensing, which also have become interested. We're not going to get into that today, but just know these are questions that permeate the almost irrespective of licensing. But that's the progress we've made together. And I appreciate you saying, Heather, that I don't think either one of our organizations could have done this alone. And frankly, this, I think, is an excellent demonstration that when we put our heads together and focus together for the workforce, we can do incredible things to make it a better environment for them.
You know, well, first of all, congratulations. This really is a remarkable milestone. And I've often said that watching this evolve has been a masterclass in scaling impact around a very actionable area. So, I know we hear lots about things that aren't going well, and a lot of times it's doom and gloom. Yes, we have a lot of work to do, yet this is something that I think that we can learn from and celebrate the progress that has been made, because this truly is exceptional work. And I will say that I also understand that in doing this work over the last few years, that our knowledge around this area continues to evolve. And I understand that we do have some new insights that you'll be sharing with the audience that have come from your work with the Heart of Safety Coalition. Will you share a little bit about that?
Sure. And Alec, you can skip and just leave it on that for a minute, because I meant to share that's the badge, as well as our 3 million. So as Heather has alluded to a few times, mentioned a few times, we are part of a national coalition that is wrapping our arms around the healthcare workforce called the All-In Wellbeing First for Healthcare Coalition. This coalition is celebrating its 5th year. Of the 35 coalition members, the Heart of Safety Coalition in and of itself is also a member. And the Heart of Safety Coalition wanted to do their part to survey workers and say, is what we see these barriers, and we see them, but we want to make sure we hear from you that this is a real thing and Heather mentioned at scale. So the Heart of Safety Coalition, together with our All-In Coalition, in September, published the results of their survey of physicians, physician's assistants, nurses, and nurse practitioners. And they asked them, what are those barriers to mental health access? Why don't you get mental health access? And the report shows that there are a couple things. One is the cost of mental health services without insurance, as well as scheduling flexibility. So that's one, and we're not going to cover that today, but I wanted to be comprehensive and say that was one. But the second one, which was really the first priority for physicians and physicians' assistants, was this issue around being inappropriately asked about the mental health pass from the perspective of licensing, credentialing, malpractice, et cetera. We've heard that in spades. What's interesting is how prominent it was. Half of the respondents said this was the reason they will never get mental health care. So when we think about the fact that you have half of the respondents saying, I'm not doing it because I'm worried about this, and what you've heard in the prior discussion here about the pace of impact, we really have an opportunity not just to change this on the paper, but importantly, communicate the new rule set. That rule set, by the way, would have potentially saved my sister-in-law's life, because in New York, that was one of the original purple states. That was where she practiced, but she never knew it. And so excuse me, that is a critical part of the survey, which is this knowledge that, or this perception that the rules are not in their favor.
Yeah. And I love that we are continuing to learn what else we need to do next and how to do this work most effectively so that we can continue to knock down those barriers, whatever they are. Daniel, I know I'm going to turn to you for a moment and ask you about your experience with from the AMA's lens. You've been active in this work in all 50 states. Are there a couple of cases, maybe one or two specific cases that you've learned a lot from in the last, 6 to 12 months, and what stood out the most to you? Anything that you think would be really helpful, new insights to share with the audience?
Yeah, there are a spectacular number, and they always start with individuals. And let me go through a few. So one of the things I see that there are like 90 some odd people on the call today, and one of the things I would say is every single person, I don't know, I recognize a bunch of names. Take a look at what your institution asks. And not just a couple of questions, but go from top to bottom. Corey mentioned validation. We read every single application, whether it's a credentialing application or a licensing application, and we read it from top to bottom, and to see what is there. And we've learned a lot, by doing that. One of the other things that we've learned is that individual physicians, nurses, pharmacists, dentists, residents, medical students. There are examples where every single one of them has been a champion at their system or their medical school or their state to accelerate this change, to get it done. So if you think that there's a problem, reach out to us. Their contact information is coming later. We'll work with you directly. But two examples. One is a large academic center in Southern California, where it took about a year. From the start, they reached out to us and they said, we're involved with Joint Medicine. We want to look at these questions also. And we started having back and forth discussions with one of the attorneys there. And as the discussions grew, and they were the exact same kind of questions that we showed earlier, as the discussions grew, they realized, okay, well, I think we need to bring in the medical staff now. We need to bring in our risk managers. We need to bring in the general counsel's office. We need to bring in other people. And so they kept realizing other people were involved, and they kept having to bring them in. What was fantastic about it was everybody that they brought in, one, they had no idea the questions existed. Two, they realized what the problem was right away. And three, they said, okay, let's fix it. In large institutions, it takes a while to fix things. And over the course of the years, we had more conversations with the system. They fixed it. The other thing that they realized, this is an institution that has a phenomenal residency-based counseling program, an opt-out, de-identified program. And they realized that they weren't even adapting these same kind of protections to that opt-out program. And then by doing that, they were able to communicate and further promote this program that more and more residents were using to discuss whatever it is they wanted to discuss in a confidential, protected way. So it had multiple benefits as we went on. The second one, which I think is fantastic, in Minnesota, probably about like 3 or 4 years ago, a medical student took his own life. And his colleagues said, this is unbelievable. This is unacceptable. This is like tragic. And, they're a close-knit group, and they said, we want to make sure that, and one of the things that this individual was scared to seek care. And so this group of medical students wrote to the medical board and said, we want to change the questions that you have. And to the medical students' surprise, the medical board wrote back and said, come and talk to us, which scared the medical students. They're like, oh my God, I have to go talk to the medical board now. But the medical board was, and this is in Minnesota, extraordinarily receptive. They worked with the State Medical Association and other specialty societies in Minnesota. They had the conversations they needed to have, and the medical board changed the questions. The medical board didn't know that there was a problem until a small group of medical students said, "We have a problem and we need your help." And that has happened. A medical student was responsible for a system in New York for changing those questions in New York. A medical student was responsible for changing the law in Colorado last year. So, and then there are dozens of examples of credentialing officers, chief wellness officers, and just individuals who work in those areas, changing it at their own hospital or health system. So those are just some of them, some of the individuals. Everybody on this call can do it. And, with the AMA, Dr. Lorna Breen Heroes Foundation, we will be your partners to help you get it done.
I think that's such a powerful message, Daniel, and great examples. So, someone's listening and they're saying, well, I'm just a medical student, or I'm not in leadership, so this is outside of my control. I think clearly we could say to them, no, it actually is in your control. And you're not alone in doing this, but there are really, really clear pathways to actually make changes in your own health system. And so maybe that's a great segue into what is that call to action. What can someone do if they're worried about this? And Corey, do you want to take this one?
Sure, I will. And I'll also not scare the group in thinking that your institution is going to take the year that in Daniel's example, because we have seen the opposite end of that spectrum as well. One of the best examples I can point to is Daniel gave some feedback to a hospital system on a Friday, and they had changed the questions by Monday. So that is a pace of change that I've never seen in healthcare, irrespective of the size. And by the way, that's a multi-state, huge health system. That is not just a very small organization without any layers of administrative bureaucracy. So what we have, this is also part of the learning question that you asked earlier too. What we've learned is that it's really important for organizations to use the free resources that Daniel talked about that are on the Dr. Lorna Breen Foundation website. Audit their questions against those materials. And those materials have that same grid that Daniel was sharing before. And it's important not just to look at your credentialing questions, it's critically important to look at your peer reference forms, because in our experience, the peer reference forms questions are often more invasive than the credentialing questions. So you audit those and then go ahead and make a draft, I would say a draft revision. And I say draft because don't go through the administrative approval process in your organization until we've taken a look at that draft. And that is that important validation process. Now, as a reminder, this costs organizations nothing. We are all doing this with our own philanthropic and grant support to cover our own expenses and our own time. This is really making sure that you then submit to us all of the forms and not just one question, as Daniel said. We need to take a look at top to bottom, because over time, these forms have been pieced and parsed together, and sometimes they internally contradict themselves, or there's at least a place where you go, gosh, I wish they had tightened that up, because they could see that as contradictory. And remembering that 50% of health workers that are already saying, I'm super skeptical of this, you gotta make it tight. So verifying it, we then issue, once we have satisfied ourselves that the changes have been made, or we'll go through further revisions and advice with you. Once that process is complete, we issue you the badge that was on the prior slide, and then give you the critical communication tools and templates so that you can let the workforce know what the rules are. That's year one of the badge process. You change it, we give you all the materials to communicate it. The subsequent years of obtaining the badge, you demonstrate to us that the changes, that you haven't made any further changes. You attest to us that you haven't made any further changes since the last one. But then you give us 3 examples of how you communicated it. And it's that that's the ongoing cycle. It's just show us you've communicated, because we know that's going to be the longer term change initiative that we've all endeavored to take. But those are the very simple steps that we've taken. And if you go to the next slide for me, You'll just see these are just some examples of the new materials that you can download for free, which include that self-audit, that revision, and our verification process. And then finally, if you go to the final slide, you can see the QR code that you can all use to immediately create a free account and download all of those materials. And so help is on the way, as Daniel said, and anyone in any organization has now the ability to be celebrated and make this change happen for your entire organization.
Thanks, Corey. And I want to say from personal experience, having gone through trying to lead these changes at two different health systems, both Daniel and Corey and the organizations that support them are just make this so much, I don't want to say easy, but so much easier. So you are not trying to do this by yourselves. They're just such a great resource. So I really encourage anyone who is interested in doing this to reach out for help. And so I also wanted to just share then that, so Corey, if listeners want to go and see if their state or their health system has made the recommended changes, they can just log on to the website and see that information, right?
That's right. drlornabreen.org/remove barriers is actually the subpage, but if they go to drlornabreen.org, you'll see it, and you just scroll down that page and all the maps come up, and that bright blue map is the interactive map that you'll want to click on. And if you're in your institution, you don't have it on that map, this is the opportunity to make it populate the map. We update the map about 3 times a year.
Exactly. And that would be my ask to folks, is to really go and look and see if your organization or your state have been certified, and if not, to take those steps there. And even if they have been, I would say your work is not done, because it is just as important to then communicate that out to everyone in your organization, that yes, it is safe to seek care and to seek support. I think at this point, let's do we have any, we can open it up to questions for a few moments, and then I do have one final question for both of our panelists here. But is there anything in the Q&A that hasn't been answered already? Anyone else have a question that you want to drop in the chat? And maybe while folks are doing that, I will go to my last question for you, for both of you, which is, we talked a lot about the why this work is so important. We talked about the progress that we've made to date, and we talked about the work that is yet ahead of us. But I'd like to dive into that last piece a little bit more. Where do you see this movement going next? What's the next frontier?
Every health worker in the United States needs to know the rules, and we need to have the rules changed so that there are no health worker in the United States, no physician, no nurse, no pharmacist, no dentist has any concern about this. And what I would say is, that licensing map needs to be all purple for physicians, and you'll see the other colors if you go to the website. That bright blue map needs to have every hospital system listed on it. Every malpractice carrier needs to be listed. There are now 2. Every locum tenens firm. If you recognize the fact that physicians in the United States have to navigate a minefield of questions about their prior mental health treatment and diagnosis in all these places, it is no wonder that they don't get mental health treatment and they're worried about it. We've done this to ourselves. And so we need to undo this to ourselves, and we need to communicate. That's where this is going. And I can't wait to that day, which is in our sights. And is very close in our sights to make this all happen.
Thanks, Corey. And Daniel, looks like there's a question in the chat, and maybe that'll be a good segue also if you have anything to add around what's coming next. But there's a question in the chat about if the questions ask about currently being in counseling, isn't that a barrier to seeking help?
Well, we don't support questions about if somebody is currently in counseling. To be clear, and I think if there is, this is always about balance. If there is, or we want to support patient safety, impaired health workers, will not need care, and so we need to remove the barriers for them to get care. By the same token, and I want to get to the what's next, but by the same token, individuals who are seeking care or are in care healthcare professionals are mandated reporters in almost every single state. And healthcare professionals have obligations that if somebody that they're treating is not safe to see others, to have to intervene in some way, shape, or form and this is too short of a time to go into that. So there are protections currently in place for that. But I wanted to end, Dr. Farley, on when I was growing up, and Corey and I, not to age Corey, but he's pretty old like me, and so we can recall when we were growing up, the stigma that was associated with seeking care for a mental health issue. It was when I remember my parents talking about, when they were growing up, people went to go visit an aunt in the country, aunt in the countryside, things like that. And it was that code. And I have a couple of teenagers and a younger daughter, and they openly talk about, that if somebody is getting care from a psychologist or a counselor or a social worker, it is no big deal. We have made a huge change. That change has not trickled up to healthcare professionals and to the systems where healthcare professionals work. So what's next is when everything is purple, as Corey said, and we're going to get there. We are going to get there, but that has to be followed by that broader cultural change that when somebody's seeking care, it is no big deal. And in fact, it is something that's saying, good, I'm glad you're getting the care you need. What can I do to help? And that is an open conversation. We're going to get there too. We might get to purple faster. But they're going to be hand in hand.
I love the optimism on this call, and that is paired with action. And I think that so well encapsulates my view of where we need to go, as well as the vision for the future is having that whole map be purple, and that we've created culture change, transformational culture change within our organization, so that it truly is okay to not be okay and to talk about that with one another. Corey, it looks like, did you have a final word?
I needed to correct the record because this is being recorded. I am not as old as Daniel. It's very important. But the other part about this that I think is really exciting, and Daniel, you just mentioned it, about the expectation of the current generation of medical students is very different about this topic. And one of the ways that we have seen this in the public eye is through the television show The Pit. And if you're in healthcare, you either know about it or you've been watching it. But if you go back to the last episode of season 1, when Dr. Langdon and Dr. Robbie are talking about the fact that Dr. Langdon needs to get substance use treatment, Dr. Langdon says to Dr. Robbie, I'm going to lose my license or credentials if I get help. And Dr. Robbie says, that's not a thing anymore. The reason he said that is because the institution that they are allegedly working in, and in the state that they're working in, we've given the badge to, by the way. They knew that. But the more we're talking about this subject in the public eye, the more that it is in television, the more that it is in real medical shows, the more we have a chance to come at this and normalize this conversation. And again, this is incredibly achievable if we do this together. And just again, I'm not as old as Daniel.
The record has captured that.
Thank you.
But, Corey and Daniel, I can't thank you enough for the exceptional work that you are doing to enable our healthcare workforce to receive the support and care that they need and deserve, and for sharing your insights with us today. I know that is still work for us to do together, and I'm very grateful that both of you and your teams are here to support everyone that is listening and everyone out there who wants to help us take this across the finish line. Thank you to our listeners for joining us today. I hope you are inspired to look up where your state and your organization are on the map, and to engage with us to help you get there. I'm going to turn it over to Alec for some final closing comments. Thank you, everyone.
Of course. Thank you all for tuning in. Thank you, folks, for your expertise today and all your hard work in this area. I just have a final few pieces to leave you with who have joined us today for this talk. I want to make sure I'm at the right spot, though. After our webinar concludes today, you will be able, no, let me get there first. There we go. That's what I wanted to be on. My apologies, folks. After this webinar concludes today, you will be able to claim, no, I'm not on the right spot. There we go. When we conclude, you will see our feedback survey. Please take the time to answer the 2 questions there. Your responses help guide our upcoming programming to deliver webinars you want to see, such as the one you saw today. This recording will be available to review on demand with the link you used to join, including access to today's slides and recommended resources. Our next webinar is focused upon inpatient documentation and coding. We will be back on March 31st, so join us as we outline key points from the upcoming simplified inpatient documentation and coding toolkit, focusing on efficient, accurate documentation that supports inpatient billing. If you'd like to attend, register now by following the link in the resources tab to register there in one step, and you'll also be able to register for our outpatient documentation and coding webinar, which will take place 2 days later. For any additional resources and guidance to support your physicians and staff, including those on engineering better well-being for physicians, please visit the American Medical Association website or stepsforward.org. Thank you again for joining us, and we hope to see you again soon.
Thanks, everyone.